In our group, a high-risk subgroup of ALL was discovered, which is called BCR-ABL-like ALL. So that probably needs a little bit of introduction into the BCR-ABL subtype. This is a well-known poor prognostic subtype that fuses two genes together, the BCR gene and the ABL gene, and this leads to activation of the ABL kinase in B cells where it should not be active. And that's the cancer-driving lesion in about 5% of children, but a much larger proportion of adults with ALL. What we discovered is that there's a group of children that's about the same size that looks like this group in gene expression patterns and poor outcome, but they don't have this specific BCR-ABL fusion gene in their genome. Another group in the US also discovered this, and so step by step we're getting closer to the identity of this group. And now it appears that there's a lot of different fusion genes, different kinases that can be partnered with up to 15 different partner genes, making this very heterogeneous group, but probably with the same outcome, which is activated tyrosine kinase signaling and then associated poor outcome. Tyrosine kinase inhibitors are used currently for BCR-ABL positive ALL. In adults, it's been used already for 10 years, and in children also, with very good results. So where these patients were one of the poorest subgroups, now they are among, with outcome among the other subgroups. So that's been a big improvement. So the next step is indeed to see whether these novel tyrosine kinase fusions would be sensitive in the same way to these inhibitors. And we're collecting, with a lot of different groups in the world, preclinical evidence to show the sensitivity. And also there's early clinical data already, especially, of course, the step to treat a different ABL fusion with imatinib or dasatinib, which are the current inhibitors, is not such a big step for a clinician. So refractory patients or relapse patients for which there's no current treatment options are being treated, and largely with success. So these novel fusion cases respond in the same way as the BCR-ABL fusion responds. And then there's a separate class that is the JAK fusions. So it's a different kinase and it responds to a different inhibitor. So these are the JAK inhibitors. And here also preclinical data is solid to show that these are sensitive to an inhibitor, such as ruxolitinib. But since this is not a standard drug in ALL treatment, the step to early clinical studies is more limited. But I think there's a similar improvement could be made in the outcome of these patients. Well, trametinib is another inhibitor because it's a MEK inhibitor. So if tyrosine kinase activation happens quite close to the cell membrane, it's a receptor or it's a kinase that's fairly close to the receptor and starts downstream signaling, and there can be different paths. And the MEK pathway is another path that could be activated. So that makes it also more complicated because tumor cells can escape by activating one of the other routes. But the MEK inhibitors are currently, well, the most obvious genetic aberration to link them to sensitivity is RAS pathway mutations. So these signal directly downstream to MEK, ERK, and then down to the nucleus where they start transcription. So in our lab we've shown that ex vivo patient cells, so we take patient cells and we do a short exposure to trametinib, that these cells die. And this is important because many of the RAS mutated leukemias are not sensitive to, for example, prednisolone, which is the main drug in ALL treatment. So by giving them something extra, hopefully that can improve their outcome. But these are really still at the preclinical stage, so not yet in patients. So the US is already starting a clinical trial where they will upfront identify these novel tyrosine activating lesions in patients and then add imatinib or ruxolitinib, depending on ABL or JAK class aberration, to the induction treatment. to see whether they respond, and if they respond, they can keep receiving the drug. So that's one big clinical trial. It's very important to see what's going to come out. Yeah, and there's other trials. There's of course many new drugs, and if you mention MEK inhibitors, there's not only trametinib, but there's many of these potential therapeutic agents that need to be tested. And the way forward now, because especially for relapsed children, the population is actually limited, so you can't test every drug you would like to test in clinical trials. The idea is to do these basket trials where patients will be pulled together based on their genetic aberration and not primarily on their type of tumor. So to increase patient numbers with each specific aberration and then to be able to test sensitivity to these different promising drugs. And so in the Netherlands, there's we have some trials going, but we'll also enroll patients in European trials simply to together have sufficient patients and power to help develop these new drugs. Yeah, you can't really look too far into the future, but sequencing costs are going down, and currently many tests are being done already together, make up also for an expensive diagnostic process. So that's one. Second, I think the clinicians need to be convinced that detecting these aberrations will really help them to improve treatment. So that is, of course, clearly a case that you would need to detect them. And I also think there will be more targeted solutions to diagnostics. These can be very simple, like FISH, seeing a kinase is broken, which now is done for BCR-ABL, but could be done for the other kinases. Followed by PCR. We can exclude the known subtypes, so they will not have to go through this more expensive diagnostic pipeline. And targeted sequencing specifically for the lesions we know will cover already a large proportion of them. So I think in that way we can balance costs and benefit for the patients, and we can have both.